Improving symptom management for patients with cancer has long been a major focus for oncology care. As of late, it has shown consistently to be top of mind for both the patient experience as well as cost savings. Last year, the Association of Community Cancer Centers conducted its 9th annual survey called Trending Now in Cancer Care. Together with the Oncology Roundtable, the survey received more than 200 responses from cancer programs across the country. When the group was asked to name the top 3 ways to save costs in oncology, 54% of respondents said symptom management was in their top 3, and 41% also cited care coordination. The survey also showed the most popular support service that cancer centers plan to add to their programs over the next 2 years is an urgent symptom management clinic. A pioneer among those joins us today. Welcome to Cancer Buzz. I'm your host, Summer Johnson. This podcast is a production of the Association of Community Cancer Centers. ACCC has put together a regular audio show to keep you informed of hot topics in oncology care delivery. As the healthcare system transitions to cost-effective value-based care, there is more focus than ever on improving quality of care while reducing costs. Lately, some cancer programs are finding creative ways to better manage the symptoms and treatment side effects that patients with cancer can have. One of these new models is the 24-hour cancer clinic, providing round-the-clock access to oncology-specific emergent care services. It's currently underway at some larger academic programs, including the Froedtert and the Medical College of Wisconsin Clinical Cancer Services in Milwaukee. Paving the way is Tina Curtis, the Executive Director of Cancer Services at Froedtert. We spoke about what made the hospital consider creating a 24-hour clinic just for oncology patients and what it took from conception to opening the doors.
We really wanted to figure out a way to how do we better coordinate that patient care, and how are we as a cancer center better prepared to take care of something that may be unplanned but not necessarily unexpected. And as we started to dive into this concept, that was really something that came through loud and clear, that some of these issues that patients were showing up with were not at all unexpected and really were just part of undergoing treatment for cancer, that we would see patients who would need these services. That aha moment for us really ended up being pivotal to say, okay, no, this is on us. We have to figure out a different way to manage the patient flow here, because it's not fair to send our patients to the emergency room for something that really we knew was going to happen, or there was a high likelihood would happen as part of their cancer care.
How long ago was that aha moment?
18 months to 2 years before the doors to the clinic actually opened. We opened the 24-hour clinic in November of 2016 and really started the planning, I would say, in early calendar year 2015. So probably a solid 18 to 24 months before the doors opened. I will also add to the conversation that my background is as an emergency room nurse, so I was probably sensitive to some of those hallway conversations I heard, or was maybe a little biased in my opinion of who we were sending to the emergency room and who we weren't. All good, but have been on the receiving end of those patients in my clinical career before I moved over to the cancer center and moved into administration. So I had some ongoing bias in the first place about what we were doing to not continue to add burden to the ED.
Did you have any hurdles that you had to get over from the leadership of the hospital?
We had hurdles all along the way. We had hurdles within our providers there's a lot of perception that the patients who were presenting to the emergency room were all very, very ill. The belief was that we were admitting a lot of patients directly to our intensive care units. So that came in a data analysis to kind of come back and say, actually, no, there's a lot of patients who are coming to the emergency room who end up getting discharged, and showing those detailed kind of patient level data that we found to tell that story of who really was the patient cohort that was in the emergency room and painting that picture. We had some really seasoned oncology nurses who had some doubts right off the bat. Can we do this? What are you thinking? So we talked through those. And then, we had everyone within the organization who was super supportive, those that questioned, and really appropriately so, as this the best use of inpatient space? Can we afford to remove 2 or 3 beds from our count on the inpatient side? And then all the way forward to, if we do this, there is the opportunity that as an organization, we could lose revenue for patients being in the emergency room. And is this something we want to do? And the beauty of it is that's a challenge in healthcare right now, is to get the patient to the right place at the right time and to really challenge ourselves to lower the cost of care for patients. And so in the end, the decision was made, we're going to move forward with the pilot and see if we can do this. It is the right thing to do for patients and the right thing to do for the organization.
Let's back up, though. Once you got approval from administration and in your Healthcare Value Council, walk us through logistically the steps to implementation and what were your priorities during that process?
So for us, once we knew we actually had space and we had to go ahead on the concept, it really boiled down to identifying first and foremost what types of patients do we feel we could safely care for in that space. So big academic campus, the inpatient unit is quite a distance from the front doors of our emergency room. And so we wanted to make sure, given that change management and having something truly new that hadn't been done before, that we were going to be absolutely safe in how we started. And so the first steps for us was really narrowing down what types of patients could we take care of, what chief complaints would we be able to do. And that was really a carry forward of what we were seeing in the emergency department, who was going to the emergency room and ultimately getting discharged, and is that something we could provide services for in this 24-hour clinic. Once that list of chief complaints really was identified, then that transitioned into, okay, how would we staff this? What skill set was needed? What equipment was needed? And it really rolled down from there. So if we're going to take care of patients who are presenting with pain control and dehydration and nausea and vomiting, here's the skill sets we're going to need. Here's the supplies we're going to need. Here's the provider coverage we're going to need. Here's what's going to happen if they need to be admitted. Here's what's going to happen when we discharge them. And so that key to it all was identifying which patients did we think we could take care of. We had to create workflows. If there was any concern, if a patient presented and we didn't feel they were safe to be in the clinic, how quickly we could get them to the emergency department. Likewise, workflows for when that patient needed to be admitted, how we would handle that. And really scoped it to start small. The belief was if we could get the doors open, take care of some patients successfully, kind of a small list of chief complaints, we could always add to that list. We could always expand the services. But on the flip side, if we opened the doors and took on too much too fast and had a bad outcome or concern among our care teams, that would really be hard to recover from.
So are you seeing a reduction in the number of ED visits so far or hospital readmissions?
We really tracked data as we went. Our first year results, we were able to show that we had very high patient satisfaction. That was one of our primary measures. We saw that we were able to decrease the rate of utilization. So we saw a decrease in patients who had radiology orders, a decrease in EKG orders, and a decrease in patients who had labs ordered. Things were fairly drastic. So patients coming to the 24-hour clinic, we were seeing things, from 11, 12% of our patients requiring radiology to 75% requiring it in the ED. And ultimately tracked our admission rate. And what we had seen prior to kicking off the 24-hour clinic is we were admitting about 45 to 50% of patients coming through the ED. And so basically 1 out of every 2 patients, the oncology patients that presented to the ED, met the threshold for admission. When we opened the 24-hour clinic, we wanted to make sure that we weren't just providing another offshoot or another avenue to facilitate an admission through. So we were really cognizant of watching that. What we saw after the first year is our admission rate in the 24-hour clinic was about 20% compared to what we were seeing still in that 40, 45% in the emergency room. So that was really important for us to make sure that we didn't just create another place with a high admission rate. So we were cognizant to try to move those patients to the 24-hour clinic that we knew were going to be admitted anyway and facilitate that through the 24-hour clinic, or weren't sure if they needed to be admitted and could triage them and keep them for multiple hours in the 24-hour clinic and then ultimately make that decision later on in their care. You don't have some of those same luxuries in a very busy emergency room to have somebody stay 10, 12, 14, 16 hours before you can make a decision on admission or not. So we had a few more luxuries. And then ultimately, cost of care, what we were seeing for patients if they ended up being admitted through our 24-hour clinic versus being admitted through our emergency department, we were seeing about a $2,500 difference in the charge that went out the door to the patient. And a lot of that was due to things that we didn't have to repeat some of the diagnostic testing. Maybe we knew where to find things in the chart a little bit more easily. But really, at the end of the day, getting that patient in front of the oncology team, there was a much more comfort level in what was going on with the patient, what information they needed to meet the admission threshold, and what tests they needed to repeat, and what information they were comfortable using that maybe was a day or two old in test results.
Let's talk about cost of the hospital and ROI. Have you seen any ROI on this yet? Is it helping your cancer program?
I would say we have not specifically gone so far as to measure a calculated ROI on what we've done with the 24-hour clinic. Anecdotally, we know it's definitely a differentiator in the marketplace. It's something we can say to patients. We have this. It's unique. It's a service. We are here for you. We are truly here for you 24 hours a day. The belief before we had opened the clinic is we were here for our patients, but maybe about 5 o'clock in the afternoon, then it was kind of like, well, clinic's closed. So, you might have to wait to see us until tomorrow, or, you're going to have to go to the emergency room because we're not here to take care of you at the moment. So we felt that we could now tell that story that we are here for you 24 hours a day, 7 days a week. You can always call us. We can always see you. We can always get you in front of that oncology team. The one thing I think that has been unexpected is having access to the 24-hour clinic was really developed to help offset that ED utilization. Kind of the magic number overall, we found a 25% decrease in the rate of ED utilization in that first year. But by having that was the ultimate goal, was to keep those patients out of the emergency room if they didn't have to be there. So we met that. The secondary thing that happened that we didn't initially realize is by having the 24-hour clinic in place and by having access to it, it really helped drive our ability as a service line to move more and more of our patients from inpatient treatment to outpatient treatment. And that was everything from our blood and marrow transplant patient population to some regimens that historically had still been inpatient. We were able to convert to being truly outpatient. And now we're having these conversations around outpatient CAR-T. Really because we know we have the backbone of this 24-hour clinic that if there is any question at all, the patient can present there and we will be able to get them immediate access to our oncology team. So from an ROI standpoint, it really helps drive some secondary efforts within the service line to pull that patient volume out of the inpatient unit into the outpatient environment. And in turn, we can backfill those beds because additional patients that are seeking care.
So what's the long-term vision for the clinic?
It's about 2.5 years now since doors opened, so nothing but positives from the patients. They have always been kind to us and have shared kind of the impact the clinic has had on them. We are at the point where we're looking at options to expand. There are times of the day that we don't have enough room for the amount of patients who are needing care. So we would really like to move beyond the space we have now to larger space so we can better accommodate those patients at kind of peak times of the day. And we are still using a model right now where we ask the patients to give us a call or to contact their provider after hours. It's not a walk-in clinic. We still have the provider make the ultimate decision as to what the right level of treatment is for the patient, whether it's to wait until the next day, if it's to come into the 24-hour clinic, or if it's to still utilize those emergency department services. Our goal in the future would be able to move that to an opportunity where the patient can either schedule an appointment online or they could even self-present, like a true walk-in clinic. There's some things we'd have to do a little differently on the front end of that process, but that's kind of where we hope to head in the near future.
Finally, what would your advice be to a cancer center or a hospital who is thinking of going down this road?
I would say two things. First and foremost, look at your data. Look at who is going to your emergency room and ask yourself, why are they there? There are plenty of patients, don't get me wrong, there are plenty of oncology patients who are going to the emergency room, and they absolutely need to be there, and that is the best place for them. But look at your own organizational data and see who is in your emergency room and why are they there? Did they self-present? Did somebody from clinic send them? Is it something that you could manage in the outpatient environment? We prompted our team kind of as we were working through all those logistics to really say, who is in the emergency room because they need emergency care? And who is in your emergency room because it is open? Sometimes later in the day or on the weekends, it's the only place on campus that's open, and that's why they're there. So really challenge yourself, look at your own data, and figure out, is there a cohort, is there a patient group that you could impact? Second to that, don't be afraid to try something. A lot of people are fascinated with the 24-hour clinic, which is great, and we were fortunate to be able to try this. Our organization has been amazing in supporting us through this, but we did this after having had a 54-bed infusion room that is open 7 days a week for 365 days a year. So we did not go from an 8-hour clinic to a 24-hour clinic. We had already had an infusion room that was open on Saturdays and Sundays and already open late into the evening. This was a next logical step for us. So don't feel that you have to go from nothing to having something 24 hours a day. This is something you can pilot. I know organizations have piloted, a single chair in their infusion room that becomes their kind of urgent patient add-on chair. I know other organizations have piloted clinics, open 12 hours a day. Don't be afraid to start somewhere. To us, this is a pilot. We were fortunate in having some extra space to do it, but it really was something that you can try at any level, and you can always expand. You can always get bigger. Always extend the hours, but don't feel that you have to go from nothing to something that's 24 hours a day. Because I think a lot of people think that's maybe where they need to start, and I think you can start wherever you're able to start and see how you can make an impact.
After I had the overview of how and what, and who to convince, I then spoke to Elizabeth Malosh, a nurse who manages the day-to-day of the 24-hour clinic at Froedtert.
In those after-hours periods, there's really limited options for where patients can go, and so often they end up going to the emergency room. And that's not to say that when they go to the emergency room, it's not, at times they are emergent needs. They might have bleeding that's uncontrolled or something related that could be a side effect of their treatment. But most of the time, what we found is that what people were going for were complications we can anticipate as a result of the treatment we were giving them. And so definitely not requiring a level 1 trauma center, which is where we are, or an emergency room in general. It could be managed in a more oncology-based setting if we were able to provide our patients with that as an option.
So describe without the clinic, what a traditional ER visit is for a cancer patient when they have nowhere else to go after hours and they just end up in the ER. How does that affect them? What are the services that they're provided, and what needs aren't being met in the ER?
The emergency room does a fabulous job of being generalist, right? The emergency room needs to treat anybody who walks in. And they look at a composite of symptoms that a patient reports, and they treat them based on those symptoms. So, for example, a 65-year-old woman may walk in with nausea and vomiting. Well, for a lot of 65-year-old women who aren't undergoing cancer treatment, that may be the sign of a heart attack. And so that workup is going to include a 12-lead EKG and cardiac workup labs and possibly some sort of imaging. Well, that might be a cancer patient who got chemo 12 hours ago and their home antiemetics aren't controlling their nausea vomiting. So when they're in front of an emergency provider, the provider has to triage them in terms of, they have to triage through the symptoms and kind of eliminate things as they go. And so in turn, they end up getting a lot of maybe diagnostics, repeat diagnostics that they don't need. The 12-lead EKG may not be needed. And so the patients end up getting a lot of extra. And also, the way we use medications or the dosing we use for antiemetics or pain meds isn't always the same as you would use for a typical healthy patient who comes in. Patients with uncontrolled nausea vomiting, might get slightly larger doses of Zofran than what somebody else needs, or they might be using something for a different use, like they might be using something for nausea vomiting that we wouldn't typically use. They also come in with a very complex medication list with different oral chemotherapies in it, different supportive drugs that a general ER physician is not going to be overly familiar with, which makes sometimes treating an oncology patient in the emergency room a little bit daunting because you don't want to do anything that's going to inadvertently interfere with their cancer treatment.
So I do want to talk about education and how you market to patients and providers, but why don't we back up? Can you explain to us how the clinic works?
When our clinic was developed, we developed in a pilot space. So our space is limited. We have 4 patient beds, and our provider coverage, we were able to leverage some new construction that happened at the time. And so we're co-located on an inpatient oncology floor. And so we were able to leverage our already existing overnight providers on the floor to provide some clinic coverage. And so because we had a few limitations around just space in general, 4 spaces for a large cancer program isn't a ton of space. And then also our provider model, we determined that for our pilot, we were not going to make our clinic a walk-in space. So our space is all provider driven. So it requires the patient to call in, whether that's during the clinic day, they would call their clinic and talk with the triage nurse in their clinic, or overnight, our triage nurse line for our health system. The patients call, and then once it's determined that our 24-hour cancer clinic might be the right treatment location for them, then an appointment is requested in that space.
So how do you set up your staffing? And is the staffing process different than a traditional outpatient cancer center?
So we have a fixed staffing model, much more like an urgent care or an emergency room would be. You know, sometimes it's a kind of a watch and wait methodology. So when we developed our staffing model, we had to plan for patients arriving. We are open 24 hours a day, which definitely differentiates our clinic. Other similar models that we've found out there are not open 24 hours. They're open maybe 12 or 18 hours, maybe traditional urgent care hours. But we wanted to pilot the concept or propose the concept that patients don't just have symptom issues at 2 p.m. or 8 o'clock at night, that sometimes they get a fever at 2 a.m. And by waiting till their clinic opens in the morning, which sometimes maybe not for a fever, but for like nausea vomiting, sometimes if they wait all the way until their clinic opens at 8 a.m, they may be much sicker than had they been able to come in and see somebody at 2 a.m. So we really wanted 24 hours to be our model. So when we were developing the staffing, initially it was just 2 people fixed 24 hours a day. And that's generally 2 nurses. During the day, we have a nurse and like a tech or a nursing assistant in there. But over time, what we found is that our arrival patterns very much mirrored that of an emergency room, which is a bell curve with the highest arrival being between 2 p.m. and 8 p.m. So we've since adjusted, the clinic's been open almost 3 years, and we've adjusted the staffing a little bit. At certain points during the day, we flexed up to having 3 people in the space. And then in the overnight hours where we have low patient arrival from about 23 to 07, we go down to 1 nurse. Some nights we have 2, depending on overlap and variance and such in our staffing, but we go down to 1 nurse. But because they are co-located on an inpatient unit, that nurse is never truly alone. There's an entire inpatient staff of nurses and nursing assistants that are there to assist that person if they need assistance or if they need somebody to double check blood or do something like that. But overall, we use a fixed staffing to run the clinic 24 hours a day with 2 people in there at all times. It required about 8.4 FTEs, and then we've flexed and adjusted that over time.
So for the cancer patient who used to go to the ER, put us in their shoes, tell us what's different, kind of paint a picture of their experience with the clinic.
So the beauty of the clinic is they are seeing somebody who understands their cancer. And we hear that a lot on our patient surveys. We use a slightly different CAP survey for the clinic than we do in the rest of the cancer network because we aren't asking about chemo wait times and things like that. We're asking more about a traditional clinic visit. And what patients communicate month after month in their comments is coming to the clinic gives me such peace of mind because they understand my treatment. They understand what the side effects of my chemotherapy are. They understand and can educate me that we're not surprised that you got a fever based on the treatment that you got, or it looks like you didn't quite take your antiemetics the way that we kind of would like you to take them. How can we adjust those? We understand the methodologies that they're using for pain control. We have access to our palliative team to consult. So the patients just express that they feel such a sense of peace because they know that when they're seeing the person, they understand their treatment and they don't have to educate every person that comes into the room on their cancer. So we understand what leukemia, lymphoma, myeloma are and what we would expect in their labs versus a solid tumor patient or the different chemos they're getting. So we have a little bit of a different treatment route. We also do a lot less diagnostics. We're not 12 leading every patient who walks in because we know that not every patient needs a 12-lead EKG. In actuality, what we found is our ER, they're doing wonderful work, but our patients, about 85% of our patients who present to our emergency room, we're getting 12-lead EKGs, and we're doing 12-lead EKGs on about 5% of our patients. So we're only doing them when we know the patient truly needs some sort of additional cardiac workup. So the patients just truly appreciate that. They get to know the staff very well. The staff is a small core of nurses and techs in there, and the patients, when they're in the throes of treatment, they may be in the 24-hour clinic a couple times during their active treatment period, and so they really get to know that space. The other really neat thing is because it is co-located on the inpatient unit, if the patient does need to be admitted, the nurse is able to, escort that patient, give a nice warm handoff to the inpatient nurse, and kind of stay in touch and follow that patient through their admission. Also, the patients will pop their head in and say, "Thank you so much, I'm going home today." And, they check in with the nurses. And so the 24-hour clinic kind of has become a nice bridge between our inpatient and outpatient program.
How do you get the word out to your patients and providers?
Early on, we did a lot of education with our providers. I went and met with all of our individual sections. So we have a lot of different smaller divisions. We obviously have the larger med-onc that is in our cancer center, but then we also have surgical oncology and the ortho-oncs and gynecologic oncology and a lot of those smaller groups. Tina Curtis and I went and met with all of the different divisions and marketed the model to our teams. And then we have a brochure that we use for patients. It's on our website. We've featured different aspects of the 24-hour clinic in our Froedtert Cancer Center annual report the last few years that goes out to our entire kind of service catchment area. We talk about it a lot when new patients are diagnosed. So whether they're diagnosed on inpatient or diagnosed on outpatient, they get educated on the 24-hour clinic when they're diagnosed and that this is an option. It's definitely been a differentiator for us. I think as we're gaining more traction and people are becoming more aware that this is a part of our program, people definitely see that as a reason to come here. I have a personal family friend who was actually treated at a different organization who didn't do bone marrow transplants, had a choice between two places in the state to get their bone marrow transplant. And in the end, because I had talked to them quite a bit about our 24-hour clinic, opted to come to Froedtert for their bone marrow transplant because they were like having that 24-hour support was such a peace of mind to them. And they used it quite a bit pre and post his bone marrow transplant versus going to the emergency room. They were able to come in at 11 p.m. on a Saturday for a fever and get in really, really quickly versus having to go into the emergency room and kind of be among the masses on a Saturday night. So it does provide just that extra layer of peace of mind for our patients. The biggest barrier I would say right now that we continue to re-educate our patients on is that they do need to call and that you're not bothering someone. So don't feel like because it's 2 a.m, you can't call and come to the 24-hour clinic and that you just need to go to the emergency room. We're here for you. That's why we developed this clinic, is so that we always have somebody available for you and that we want you to take advantage of that.
What would you say is your biggest challenge in managing a 24-hour clinic that you wouldn't have anticipated from your experience in a daytime outpatient center?
I think just awareness. I think we are kind of a small niche service. I would consider it, we've been throwing this term around a little bit, but I feel like we call it almost like a clinical decision unit. It's a nice spot to bridge when we're on the fence of does this patient truly need admission or not, but just awareness. It's funny because on our campus, we just are on a very large academic campus. So sometimes something that's only 4 beds can get a little bit overshadowed at times. And because we're kind of straddle both environments, we're not located in our outpatient cancer center. So sometimes we get lumped with inpatient, and sometimes, because we're not inpatient, we get lumped with outpatient. So I would say that's been probably our biggest struggle. The other thing has been how to evolve our provider model so that we can get to a fully walk-in care model, because trying to determine what the right provider coverage is and what the right mix is depending on the time of day has been challenging. And because there isn't really a model to base yourself off of, you can't really use evidence to find best practices, so we're kind of evolving as we go, which is exciting, and you learn a lot that way, but at times can definitely be a challenge.
Lastly, to any potential managers who are going to be in charge of a 24-hour cancer center, what would your advice be to them?
I'm an oncology nurse by background, so I'm really passionate about oncology. And I think the key to this and what we always kind of market, whether it's with patients or with the staff or with providers, is this is just the right thing to do for our patients. Cancer patients have a lot of challenges and a lot of barriers and things that just make the journey difficult. And the 24-hour clinic is just such a great example of putting the patient first and making their journey just a little bit easier and supporting them through what for many will be the most challenging time of their lives, their families' lives. Anything we can do to help decrease that strain. And I think anytime we're struggling with figuring something out or struggling with how to operationalize something, just trying to keep that at the center of our mission and why we developed this clinic in the first place really grounds our team, it grounds me, and just helps keep us focused on why we're here and why we're so proud of the work we've done.
In 2018, the cancer program at Froedtert received an ACCC Innovator Award for their dedication to quality patient care and their approach to reducing ED visits and hospital readmission rates. We would like to thank Tina Curtis and Elizabeth Malosh from Froedtert and the Medical College of Wisconsin for sharing their experience. To learn more about the 24-hour cancer clinic or the Trends Survey, you can find show notes for this episode on the ACCC website at accc-cancer.org/podcast. Thank you for joining us for this inaugural episode of Cancer Buzz. I'm Summer Johnson. I'll see you next month.